Good evening and welcome to the grand finale of the 33rd season of Doctors on Call. Tonight we're here to talk about the diagnosis and treatment of high blood pressure, as well as its potential complications. I'm your host, Dr. Erik Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. We are ready to take your questions. You can call in locally at 218-788-2844 or toll free at 1-877-307-8762. And we have a great panel here to answer those questions. Dr. Mary Owen, a family physician practicing for the Mille Lacs Band at the East Lake Clinic in McGregor and a faculty member at the Medical School Duluth. Dr. Paul Sanford, an internal medicine physician with St. Luke's Internal Medicine Associates, and Dr. Erik Wendland, nephrologist with Essentia Health-Duluth Clinic. Our medical students answering the phones tonight are Rachel Hines from Lake Crystal, Minnesota, Courtney Klinkhammer from Sartell, Minnesota, and Morgan Mensink from Preston, Minnesota. And now on to tonight's program on high blood pressure. Dr. Owens and Dr. Wendland, welcome to the program as first-timers. Nice to have you here. And Dr. Sanford, welcome back again. Always a pleasure. Dr. Owen, got to keep the S off that. Dr. Owen, and one of the reasons Owens comes up is Ben Owens was one of the patriarchs of this program so many years ago.
Oh, okay.
And at least to bear a little bit of thank you to all the work that he did. So if you hear us slip into Owens,
my
that's
uncle.
why. That's right.
I'm
Anyway,
just kidding.
to start the program off, what are the normal blood pressures for adults?
For most adults, at least up to age 60, you want a blood pressure of less than 140 over 90. If they're older than 60, you want to aim for 150 over 90.
And Dr. Sanford, then, what is the 150 and the 90, what do those stand for?
Oh, those represent the upper pressure exerted by the blood on the artery walls and the lower pressure. It'd be like if you stood on a garden hose. The initial pressure that first distorts the garden hose is the systolic pressure and the diastolic pressure, and then the last pressure before you completely close off flow is the systolic pressure.
Before I forget the question, I just recently learned, I didn't know this, and Dr. Wendland, you might have some comments on this, that for the older person, the systolic pressure is more important for us to treat, and for a younger person, the diastolic is more important to treat. And the reason is that as you age, you need that diastolic pressure to perfuse the heart.
Yes, the coronary arteries, the arteries that serve the muscle of the heart that has to beat, they actually fill when the heart is resting. So the heart pumps forward and then relaxes, and then the blood actually flows backwards into those coronary arteries. And if in elderly people, as their blood vessels get stiffer just from ordinary aging, they don't store the energy of the contraction of the heart, and so there's no backflow into the coronary arteries. So if you give them too much medicine to lower the systolic blood pressure, the top number, you can make that pressure that perfuses the heart, that gets the blood to the heart, a little bit too low. And so yes, you generally don't want the diastolic to go too low, and that's why you sort of, as Dr. Owen mentioned, you can let people who are a little older have a little bit higher blood pressure. Sometimes they need it.
And I think we'll get into more of this discussion that's from the JNC8. I think two of you have at least reviewed it pretty well. Tell us, what's the best way to take a blood pressure? Because in my clinic, all of a sudden it's changed, and I suspect in others too.
Well, in the office, the best, well, anywhere, just body position, you should be kind of sitting just like I am here, back supported, seated, feet flat on the ground, no crossing of the legs, and the cuff should be sort of around your upper arm, and should be at the same height as your heart, sort of maybe resting on the table or even, you know, the nurse's arm who's taking it. Should have been resting for 5 to 10 minutes, and also really no caffeine, nicotine, or exercise for 30 minutes before you take it. And that's pretty standard for outpatients too, if people are going to take it on their own at home.
Dr. Owen, Native America has difficulties with several illnesses, and I believe hypertension is one of them. You want to speak to that just a little bit?
Actually, hypertension in Native Americans is about 25% of our population, which is lower than for non-natives. For white population, I believe it's at 33% for women and 31 for men. So, correct me if I'm wrong,
Yeah, I
but
don't know.
for
It's
Native
high,
Americans,
yeah.
it's about 25, 26%. So,
Yeah.
one of the few areas that we're doing better in. So, good question, though.
Mhm.
One of the first questions that come in is about salt.
Yeah.
Paul, what are some of the physiologic things that before you've determined that I got high blood pressure?
Oh boy.
What's the first thing that I should do?
Well, when people have high blood pressure, you try to reverse the things that are reversible. If you're overweight, we try to work on losing weight. If you're eating a lot of salty food, it does make people with high blood pressure have higher blood pressure. If you don't have hypertension, salt probably can, over the long term, add more problems. But in people with blood pressure, try to reduce salt. Try to avoid salty foods. Anything that comes in a can or jar is going to have a lot of sodium phosphate and other forms of sodium salt. So those are the big things we try to do, that and regular exercise, and try to avoid your cheeseburgers.
Erik, there's been some discussion about the importance of salt. Do you have some comments on sodium, or are you in agreement?
Yeah, I would say, I mean, a certain percentage of the population, it's nearly half, who have been diagnosed with hypertension, high blood pressure, can actually lower their blood pressure on their own just by reducing the sodium in the diet. We as humans were kind of designed or evolved, whichever you believe, to hold on to sodium when it's scarce, and when we live in an area of abundance, it can accumulate, and that's part of the how some people think that's how essential hypertension, which we don't really have an answer for yet. That's the most common kind of just hypertension developing. How that it could be from salt. So yeah, the average American diet is about 5,000 milligrams of sodium per day, and really the American Heart Association recommends 2,300 milligrams, so about half or less of the average diet.
Mary, how often should a person have their blood pressure checked?
If their blood pressure is out of control, greater than those, or actually it's greater than 120/90, then it should be annually. If they're below that, then it should be about every 2 years. Of course, if they have other health problems like diabetes or heart failure, other heart problems, then it should be definitely at least annually.
Why treat blood pressure?
Anybody? Or,
Yeah, go ahead.
well, untreated blood pressure can cause damage to the kidneys, the heart, the vessels in the brain. We could probably reduce a large proportion of the number of strokes and heart attacks by just reducing blood pressure. And it's always nice to have working kidneys. So if we can keep our blood pressure where it should be, less reduced risk of ending up having somebody taking care of us when we're 75 in a nursing home.
Mary, there's a question on white coat hypertension. Do you want to address that?
White coat hypertension is, I believe, about 20% of the people who have hypertension have white coat hypertension, and it's the elevation in blood pressure that patients sometimes get when they walk into an office and see someone as scary as Dr. Christensen.
Well, they made up my face. I shouldn't be so scary tonight.
I would say
When they
that
see physicians, pardon me.
I would say the ad that this gets back to taking blood pressure home, but people who, and that's called ambulatory blood pressure when you're not in the doctor's office. People who have only white coat hypertension, where it's high in the doctor's office but fine at home, less than 140/90, that's not as bad for you. It's not associated with as many strokes, heart attacks, kidney failure
Correct,
as white coat hypertension.
Right.
Do you all have the ability to do mobile or blood pressures at home? Other than monitoring, do you use monitors that are repeat, what do I want to say, that record on a periodic basis during the day?
You can sign up for those.
You can get those now.
Yeah, our clinic has just a cuff that we send out with people. They can take.
So they just do their own blood pressures the way you do.
Right.
Usually, yeah, they just purchase their own cuff. Often, if you get a doctor's prescription for it, the insurance company will pay for it. And So yeah, usually it's people with their own cuffs, and even going to, I don't know, I think some pharmacies have their own cuff where you just put your arm in there.
That's what I've suggested to my patients, go to
yeah.
Walgreens.
Yeah.
Mary,
It's not best.
at what age, with a family history of hypertension, should you start getting your blood pressure checked?
That's a good question. I don't know that one.
12.
Well,
Well,
yeah, I
he-
mean, children. We're talking mostly about adults, but
Yeah.
children get at least screened every year, I believe, and they have very strict criteria based on their age and weight. To have a pediatric or child patient with hypertension, that's a big deal.
Mhm.
If really, if you have a family history, you're still going to get it checked every
Yeah.
year, every 2 years, and I don't think any more than that. It's a
But you're
little
not
bit
necessarily
different than
gonna
colon cancer or breast cancer in terms of screening, because even if you're normal, you're going to get it checked every other year, and if you're close to being abnormally high, then you're going to check more often.
It gets checked at school physicals as a child and
Yeah.
all those
Mm.
times.
Or in clinics for your school physical.
Right.
No, that's true.
Mm-hmm.
When you're treating blood pressure, so we talked about some of the physiologic things, salt. What other things, Mary, are there other things that you advise?
Well, I think you mentioned exercise and weight loss. If you combine those, that drops your systolic blood pressure by the top number by about 9 in itself. So if you add those to the recommended diet that for hypertension, and the salt, decreasing the salt down to about 1,500 milligrams, which is pretty significant. That would be another 10, the
Mhm.
DASH diet and the salt. So
Mhm.
And avoiding alcohol.
yes, right.
Does alcohol raise your blood pressure?
Sure.
About
Does
3 to 4
smoking raise
points
it?
you could take it out.
Smoking doesn't raise it probably, but it shortens your life. So
Plus, the whole point of high blood pressure is the risk to your cardiovascular system, your blood vessels, your heart, your brain, and your kidneys. And smoking is every bit as bad for that cardiovascular system as hypertension. And when you put the two together, it's
Pretty much
you know,
doubles your risk.
right.
Then you add diabetes.
Right.
oh
Right.
boy,
Triple it.
yep, nasty.
Every one of those factors is additional in decreasing your life.
So you guys changed the chronic kidney disease definitions a few years, nephrology did. Do you want to talk about the CKD and
Yeah.
some of the guidelines?
Sure. So chronic kidney disease just means your kidney function is reduced. And the way typically that's checked, and it's checked in at least annually in everybody who has high blood pressure as a diagnosis, it's 2 ways. You check a test of the urine. The kidneys take blood and turn the poison in the blood into the urine. And then they check a blood test called a creatinine. Well, a lot of people who go to doctor's office frequently know that test. And when you see like protein in the urine or a high level of this creatinine, that tells you there's something wrong in the kidneys. And depending on how high that is, you could have different stages of chronic kidney disease. And really, you take creatinine and make it into an equation. This is getting very complicated. But there are 6 stages of chronic kidney disease. And really, we start to become most concerned at stage 3. So 1 and 2 are only relevant if you have a lot of protein spilling in the urine. But 3, 4, 5, and then 6, which is just end stage, like dialysis or transplant, are where you're really focusing on the blood pressure. And that's if you start at 3 if you're less than 60% of kidney function, basically. So it's, and then after 60 down to 30 that's stage 3, and then from 30% down to 15%, that's stage 4, 15% down to end stage kidney disease is stage 5, where you're making preparations for dialysis or transplant. So the important things to remember are the number 2 reason why people end up on dialysis, meaning their kidneys stop working completely, is high blood pressure. Number 1 is diabetes. Often people have them both together. And the other thing is you progress through the stages of chronic kidney disease, and you can reduce how fast you progress through the stage and how fast you get to dialysis by keeping your blood pressure under control.
For either one of you, primary care docs, does that affect how you're treating your patients or their hypertension these days?
I mean the chronic kidney disease
Right.
stratification. Not really for me. I just try to come back to the things that Grandma used to tell us to do. Eat your fruits and vegetables as close to the way as Mother Nature made them, and exercise and don't smoke.
So a 10-pound weight loss will do what for you?
Do a lot. I mean, unless you weigh 10 pounds too little to start with. But if you're overweight, you know, any weight loss makes a big difference in blood pressure and overall well-being.
But it'll drop your systolic blood pressure by about 4.5
Yeah,
points.
that's
I
real.
do start checking, as the chronic kidney disease progresses, I do start checking hemoglobin, hematocrit, and I believe vitamin D levels at a certain point. And I don't know if those guidelines have changed. If I should.
Yeah, so as your kidney function gets worse, certain other things happen. The kidneys not only filter the poison out of your blood, but they handle vitamin D, they make it into its active form. They handle phosphorus and calcium, which make your bones hard. And then there's a hormone that can go haywire called the parathyroid hormone. So we check all of those. And then, yes, your kidneys actually tell your bone marrow when you need more red cells, which carry oxygen. And if you have a reduced number of those red cells, then you will become anemic, and that's why you check the hemoglobin. And there are various treatments for those things.
Yeah, the kidney is the smartest organ in the body.
Switch a little bit. Wrist blood pressure cuffs. Mary, how accurate are they?
I can't give you a number on their accuracy, but I don't trust them very much. So
Not at all.
Yeah, I think that's pretty much unanimous. You need an upper arm blood pressure cuff. I think the good ones with the digital display and the memory generally cost $40, but it's kind of one of those investments. If you're going to buy something that doesn't work, then that's just lost money versus hopefully the insurance company or Medicare would pay for a nice one.
So how often should you check your blood pressure at home? I hear all kinds of answers to that one too.
well, if you're going to start doing you might use ambulatory, like you were speaking of, if you suspect the person does have white coat hypertension, you want to rule that out. Then you'd be, I don't know how frequently you'd be doing it, but you would want to use it in that case. As far as more frequency, I don't know.
Yeah, I think too many people tend to concentrate too much on their home blood pressures. I'd say if their blood pressure is controlled, once every 3 months, but certainly not every day unless you have some really rare and unusual forms of high blood pressure.
If you're generally for adjusting medications, I have people check it a couple times, 3 times a week maybe, and then keep a log of it and bring the numbers back in, because we know if they're doing it right, those are more accurate than what I'm seeing in the office.
What time of day?
I like it any time of day, really. First thing in the morning, before lunch, before bed. There are all kinds of complexities to hypertension. There's people who have a really high spike in their blood pressure first thing in the morning. When their medications are wearing off before they take them again, you wouldn't want to know that. There are people who their blood pressure doesn't decrease at night, and that's even if you look like you're well controlled, if you don't have that nighttime dip in your blood pressure, that's also a risk for cardiovascular
Well, there's
problems.
some encouragement now to take medications at bedtime,
Yeah,
to split your medicines, say some in the morning, some in the afternoon or evening.
right. Not only do you capture that dipping effect, but you also can minimize side effects. If you're going to have a side effect to a blood pressure lowering medication, like feeling lightheaded or dizzy, you're going to be laying down and hopefully asleep and not notice it.
So do you encourage your patients then to take it at several different times a day, you too?
If they're not already established on a
Yeah,
dose
right,
of meds
right,
that's
right,
working,
Right.
yeah, and I expect them to be higher in the morning. Your adrenaline and adrenal function is highest right before you wake up in the morning, and then just goes down gradually as the
But
day
if you're
goes on.
following them through the month to make sure your medication is working, so
Yeah.
you don't just ask for one, you don't tell them check it one time a day. You ask them to spread it out.
So let's use a
In other words.
patient. This is a person that's calling that's taking medications, and she or he is wondering about the function of each medicine. Amlodipine 2.5 in the morning and losartan 100 milligrams at night. Why are they taken at different times? And I think we've started to answer that, but do you want to?
Well, both of the medicines dilate the blood vessels to reduce the blood pressure. Amlodipine is a low. The maximum dose of amlodipine is 10, and 2.5 isn't
Pretty low.
close to the maximum dose. And so if someone's up walking around, they're not going to feel lightheaded. And that losartan 100 is a pretty high dose.
That brings up a good question, too. It seems like we do a lot better with a mix of blood pressure medicines than we do with a whole lot of one medicine.
In some cases, and as far as compliance, it's easiest to take one pill or take them all at the same time. I mean, I tried to take things twice a day, and I can't do that. But yeah, if we can get all of our blood pressure control with one large dose of losartan and have to avoid another pill with possible side effects like the swelling you can get in your legs from amlodipine, it'd be nice to just use one pill.
So what's a good starting medicine then?
Cheap one, something like hydrochlorothiazide, or if you're a male with a big prostate and it's hard to urinate, something like clonidine, an alpha blocker. Or if you're a nervous person and have
That's got a lot of side effects, though, too, doesn't it?
well, but you can make those side effects work for you. The alpha blockers help to not only reduce blood pressure, but also help to improve urinary flow past a big old nasty prostate.
Other thoughts? What about diabetics? What's the best medicine to start diabetics on?
Yeah, we were talking about that before the show started. ACE inhibitors and angiotensin receptor blockers
Like
traditionally.
losartan is an angiotensin receptor blocker. Yeah, they're called ARBs. ACEs and ARBs are sort of,
ACEs are usually the prils, lisinopril, allopril.
yeah. Interestingly, the new guidelines that came out make recommendations on different populations. Like they sort of separate it into black or people of African descent and non-black. In non-black, it's thiazide diuretics, ACEs and ARBs, and calcium channel blockers like amlodipine. And then in blacks, it's thiazide diuretics. So Dr. Sanford's right that those thiazide diuretics are old standbys. They're very inexpensive, and they're the first line therapy, even though they're like 40 years old.
How about somebody that's got a lot of fluctuation in blood pressures, 180, 120 during the day at various times? What do you do in that situation?
Well, you try to find out when their fluctuations are happening, and if there's some effect. You mentioned clonidine. Clonidine tends to wear off, especially the older forms, and then you get this rebound that can be worse than if you never took the medication in the first place in the high blood pressure. So some medications like that are longer acting might not give you big spikes. And again, if you have a big morning spike, maybe you want to take in your blood pressure first thing in the morning. You wake up and it's 180. Maybe you want to try something at night. So 8 hours before you wake up, it's reaching the peak concentration in the blood.
Mary, is it correct to take lisinopril and hydrochlorothiazide at the same time, or should they be different times?
I think that you
We've already kind of hit it, but
can, but I don't.
Easier to remember.
Right. I think if you're tolerating it
I
well,
don't remember
and you take
anything
all your
against that.
medications every day at the same time,
Yeah.
it's not helping you if you're not taking it, and that's why combination
Amen.
pills are helpful too. Even though the brand name drug companies make money off of it or something, but and they can be more expensive. But if you're taking it at the same time because that's when you remember, that's the best thing to do.
if it's under control, the blood pressure is under control, does it stop? We're picking on you a lot, Eric. Does it stop chronic kidney disease from progressing?
It will not stop chronic kidney disease from progressing, but it can slow how fast chronic kidney disease progresses. Even in diabetics, even more than keeping the blood sugar under control. I see lots of diabetics in my office that have perfect A1C, and that's what they put all their heart and soul into, and then the blood pressure comes second, but the blood pressure is just as important to people with diabetes.
Mary, this person hears the heartbeat in their ears. Is that associated with high blood pressure?
No, it's fairly common to hear your heartbeat in your ears.
And I think we've already answered the question that losartan is not harmful for diabetics, but it's helpful. Is that correct?
Mm-hmm.
It's an
Yeah.
ARB. Diastolic dysfunction. Somebody want to take that on? Somebody over 75 years?
Yeah, it's where the heart has a hard time relaxing after it's squirted the blood out to the arms and legs and brain. The second phase is where it relaxes to refill, and diastolic dysfunction means that it may be stiffer, less compliant, and has a harder time refilling.
Is there a certain amount of vitamin D you should take? Fast answer.
2,000?
Yeah, I mean, Yeah, if you're high blood pressure, you should just take enough to keep your level above 30, 1,000, 2,000.
I want to thank our panelists, Dr. Mary Owen, Dr. Paul Sanford, and Dr. Erik Wendland, and our medical student volunteers, Rachel Hines, Courtney Klinkhammer, and Morgan Mensink. This has been our 33rd year, and it's now come to close. Remember that you can review these topics at www.wdse.org. We'll be back next fall to discuss what's new in medical topics, again from blood pressure to heart disease, cancer, and joint replacement. I want to take a moment to thank Linda Liskowitz for all the work that she's put in making this show happen. I thank the docs. There's been many that have been here, and I appreciate their time. And if you have a doc that you'd like to see, tell them. And I'd like to thank the panelists and my fellow hosts. And most of all, thank you for watching. Good night.